Hello, everyone. We can now start the session.
Wonderful. Welcome, everybody, to the 53rd MENASO Education Academy Cerebrovascular Grand Round webinar. And today we're going to be discussing on what to expect from the next generation of balloon guide catheters in acute ischemic stroke treatment. As most of you may be aware, but for some of you that are new to this series, this has successfully brought together our community of over 9,000 participants over the last year. And building on that momentum, we are thrilled to present this year's sessions in collaborations with leading international societies, offering the latest research insights and thought-provoking lectures to advance cerebrovascular care. Today, I'm joined by my speakers, and we will be exploring the complexities of cerebrovascular medicine, initially with Dr. Seby John, who will be discussing the evolution of mechanical thrombectomy in acute ischemic stroke. He'll be going over techniques, devices, and indications. Subsequently, we're joined by Dr. Professor Wim van Zwam, who will be covering the state of balloon guide catheter treatments in acute ischemic stroke. And subsequently, Professor Tobias Behrens will present the straight trial final results with a new generation Bobby balloon guide catheter. So Dr. Seby will go over an introduction with regards to thrombectomy and devices, and then we're really going to get into state-of-the-art with balloon guide catheters. So without further ado, it's my pleasure to introduce my colleague, who I work with every day, Dr. Seby John. He's an associate professor of neurology. He is a stroke neurologist and neurointerventionalist par excellence at Cleveland Clinic, Abu Dhabi. And without further ado, Seby, I hand it over to you.
Thank you very much, Irteza. Thank you for the MENASO committee for inviting us for this talk. Let me just share my screen. Can you allow me to share the screen, please? Do you see my screen?
Yes, we do. Go ahead.
All right, wonderful. I'll put my timer on. Okay, once again, good evening, good afternoon, everybody. So we are very privileged to have, two leading neurointerventionalists who are going into the nitty-gritty of mechanical thrombectomy and devices and techniques. But what I thought I'll do for the wider audience is just to give a very broad overview of mechanical thrombectomy. What are its indications? What are the devices we use? And briefly, what are the techniques? I do not have any disclosures. So as I said, this is meant to be a very rapid, a brief overview, so more broad, touching upon the points that we discussed with regards to mechanical thrombectomy in acute ischemic stroke, and then we go into the nitty-gritty. So a little bit of history. This is the PROACT 2 trial, and this was in 1999. After IVTPA came out in 1995, there was, of course, enthusiasm about furthering treatment. And this was the first trial which used, this was the first positive trial which used pro-urokinase in MCA occlusions within 6 hours, which showed a positive benefit, despite there being a signal of higher hemorrhages. And then from then, it took a long while to get, really good evidence. And just before the onslaught of positive trials in 2013 was actually a quite concerning year for mechanical thrombectomy, when multiple trials came out which were neutral and did not show any benefit of mechanical thrombectomy over standard of care. But in 2015, we had 5 major prospective randomized controlled trials, which, without a doubt established the benefit of mechanical thrombectomy over usual care in anterior circulation large vessel occlusion. So actually, this is the 10th year anniversary of MR Clean. And again, we are very fortunate to have Professor Dr. Zwam, who is actually the principal investigator of MR Clean. And this is for large vessel occlusion in the anterior circulation, so essentially an M1 or ICA. And you can see all these therapies, how robustly, significantly positive mechanical thrombectomy was compared to medical management. So this was the case in the most pragmatic design, least selection in MR clean, which had, a very non-restrictive inclusion criteria with the CT aspects. To extend IA, which had more restrictive, more selected population, and you can see the difference in effect size of a good outcome, which was defined as 0 to 2, which is basically functionally independent. So Hermes is the first 6 randomized controlled trial in the early time window, 6 hours. And again, it demonstrated a very positive effect of mechanical thrombectomy, including those who received IV alteplase versus those who didn't. And whether you slice and dice this data in any way with regards to age, with regards to aspects, the location of the clot occlusion, NIH stroke scale, essentially every single thing showed a very, very strong favor in terms of performing mechanical thrombectomy. So the AHA guidelines came out within 6 hours. This was a slam dunk. Patients with a M1 occlusion or ICA with good aspects. And this was defined as 6 or greater. And we'll come into this later as to why. So what changed? Certainly, there was better selection of cases, better selection of the trials, but essentially what we used before was quite archaic devices. So on the left, this was what we used to use initially, this corkscrew kind of device called the Mercy, and you can see later iterations of it, which was basically supposed to, drill into the clot and try and pull it. And on the lower left, you can see the separator devices, which were basically used to macerate the clot and suck on the clot while doing it. These were clearly not very effective. And come in the late 2000s, you could see the new stent retrievers and aspiration catheters, which really changed the game in terms of mechanical thrombectomy efficiency and effectiveness. Basically, we were very confident of going into a case knowing that we are going to open up the artery. So this was kind of the evolution of techniques and devices. So if you look in the on the right hand upper and lower images, we started using the stent retrievers to engage the clot and pull it out, sometimes in combination with these large aspiration catheters. This was also a game changer because this was very navigable. You could get it up all the way to the face of the clot, use it either in combination with the stent retriever or use it just with the aspiration catheter itself to suck on the clot and pull it out. So this, in essence, changed the playing field for us in terms of opening up these large vessel occlusions very, very effectively. So what was next is, can we do anything outside of 6 hours? And then we went to the time window of 6 to 24, when we started using images like this, perfusion imagings, to really select out patients who would maximally benefit from these procedures. So this is showing a very good patient with the right MCA occlusion, showing a very small core, as you can see by CBF less than 30, and a large penumbra where you can see Tmax greater than 6. So the Dawn and the Diffuse trial came out. These were late window trials, which specifically used additional multimodal imaging, CT perfusion, to carefully select out. So essentially cherry pick the very, very good patients who are going to benefit. And the results were, astounding. So this is Dawn, where a very marked improvement in effect size compared to the early window in terms of improved outcome of MRS 0 to 2. And similarly in Diffuse, you can see the numbers are almost similar, 45 versus 17%. So very, very powerful treatments. So if you look at early window Hermes and the late window, the number needed to treat got even better. So in the early time window, it was 3. And paradoxically, almost it became lesser. So you just had to treat 2 patients to get a benefit in the late time window. This is probably related to the effect of intravenous thrombolysis. So you can see that the control arm didn't do as well in the late window. And this is probably because they did not receive intravenous thrombolysis. But these number needed to treats are absolutely incredible, right? This is one of the strongest treatments we have in medicine, even stronger than defibrillation for, cardiac arrest. So Aurora is the equivalent of Hermes in the 6 to 24 hours. And you can see it included few more studies, including Escape, Revascat, Resilient. And the same story, whether you look at any outcome, if you look at an ordinal shift of MRS, if you look at an MRS 0 to 1, 0 to 2, early neurological improvement, everything was robustly in favor of mechanical thrombectomy. And a similar kind of picture compared to Hermes. Doesn't matter how you slice and dice it, when you carefully select based on perfusion, even in the late window, mechanical thrombectomy was extremely, extremely effective. So this came into guideline with the use of criteria as described in the Dawn and Diffuse trial, extending mechanical thrombectomy for anterior circulation stroke up to 24 hours. So where do we go next? So this is the large core trials. These are a slew of trials which have come out in the last few years. And these are the 6 trials which now are, again, changing the face of mechanical thrombectomy. I won't go into much details, but essentially what are we looking at? We are looking at patients with large cores. So this is aspects less than 6, right? So we're looking at 0 to 5. So the earlier studies looked at, on the more favorable 3 to 5 aspects, but the more later ones. So if you look at last day in particular, they included patients with aspects of 0 to 5. And this is a very busy slide, but essentially I just wanted to show you last day. So last day, almost half of the patients did indeed have an aspects of 0 to 2. And these were patients who were treated within 7 hours of symptom onset. And the rest, you can see medical management versus endovascular thrombectomy. And these are the results. So essentially, it's the same story across all trials except the Tesla's trial, which was neutral. But in terms of outcomes, MRS ordinal shift, if you look at an MRS 0 to 2 or an MRS of 0 to 3, mechanical thrombectomy was better than medical management to get these favorable outcomes. So this is, again, a paradigm shift in the way we used to think about stroke for anterior circulation, large vessel occlusions, in the sense that even if you have low aspects, these patients still benefit. So there are many, many meta-analyses out there. This is one of them. So if you look at all the trials put together, again, if you look at MRS shift, favors mechanical thrombectomy. MRS of 0 to 2. Now, you can see these numbers, right? About 20%. So clearly different from the early time window or the Dawn diffuse kind of patient, where up to half of them would achieve functional independence. So certainly lesser than that, but still better than medical management. And the same for MRS 0 to 3. Now, in the early time window, basically 0 to 24 hours with good aspects, generally you don't think of mechanical thrombectomy as life-saving, right? It is disability sparing. But for large core, in at least 2 of the trials, tension and last day, there was actually a mortality benefit. So if you look at the last trial, there was almost a 20% difference between patients who passed away getting medical management. There is a slightly higher rate of symptomatic intracerebral hemorrhage in the large core patients undergoing mechanical thrombectomy, but there was no difference in mortality and there was no difference in decompressive hemicraniectomy. So just because you do the thrombectomy doesn't necessarily mean that you may avoid a decompressive hemicraniectomy. This is, again, showing most of the ways, most of the parameters, whether you dichotomize it by age, by location, NIH aspects, core volumes, right? Less than 70, greater than 70, and sometimes even larger thresholds, mechanical thrombectomy seem to help. So we do have some long-term trial data from these 3 trials in which the benefit of EVT extended up to 1 year. So essentially this treatment effect is real, right? But decision-making is nuanced, decision-making is complex among these patients who have large cores, and certainly you have to take into consideration the patient's wishes, other possible criteria like frailty, etc., and advice best on how they would do if they receive mechanical thrombectomy. Now, I didn't touch upon what is the imaging, right, going forward, because you could basically simplify imaging to keep it very pragmatic with just using a CT-CTA. Do we even need advanced multimodal imaging? I'm not sure we have all the answers yet. There is new data coming up For instance, how hypodense is the lesion on a CT aspects. This concept of net uptake of water, the more hypodense the lesion, probably the less viable the tissue. So there may be some magic numbers of 26. So if your net water uptake Hounsfield's unit is 26, and if your volume of stroke is greater than 26 cc, maybe this is not a good patient to revascularize. And I'm sure we're going to hear more about this. Basilar artery occlusion is a problem we've struggled with. Very poor mortality, very poor outcomes with up to 80% mortality with left recanalized. And we had initial studies, basics and best, which showed neutral results with mechanical thrombectomy. But then we had 2 trials coming out of China. This was the Attention trial, which showed that thrombectomy did improve outcomes compared to best medical management. There was a slightly higher rate of complications, a slightly higher rate of hemorrhage. And this was essentially the same in another trial, also exclusively out of China. This is the Bauer study, which also showed that thrombectomy was better compared to medical management. So complication rates were higher compared to, anterior circulation LVO, in the low teens. But you have to remember that these were exclusively in Chinese patients, and there's a high rate of intracranial atherosclerotic disease. And these patients did receive adjunctive treatments, including angioplasty, stenting, and additional antithrombotic medications. So basilar artery occlusion, basically the community has moved to, if the patient comes in with a relatively good-looking scan, you can look at the PC aspects, posterior circulation aspects. And if their NIH is moderately severe, greater than or equal to 10, most would favor proceeding with a thrombectomy. The latest in the story is medium and distal vessel occlusion, right? So we are pushing the envelope. We've looked at early window, large window, very good looking scans. Then we looked at, poor looking scans. And what do we do about more distal occlusions? So these are the trials which came out this year, presented earlier in the year at International Stroke Conference. So this is the ESCAPE MEVO trial, which looked at intervention within 12 hours in these vessel locations, M2, M3, A2, A3 of the ACA, P2, P3 of the PCA. So this is a kind of a diagrammatic overview of how these vessels would look like on a CTE and an angiogram. Certainly not, the large vessels which were studied in the initial trials, the ICA terminus or the M1. And is there benefit of performing mechanical thrombectomy over standard medical management? So essentially, this was a neutral trial. If you look at the modified Rankin scale, which they picked 0 to 1 as the primary outcome, there was no difference between those who received mechanical thrombectomy and those who underwent standard care. The same was true for 0 to 2. And the distal trial was similar, looked at 24 hours. In this, they opened the non-dominant or a co-dominant M2. And of course, the other vessels, M3, M4, the third segment, up to the third segment of the ACA, up to the third segment of the PCA. And this, again, was a neutral study, and there was no benefit of EVT compared to best medical management. So multiple factors to consider. The patients in these trials were certainly older, in the 70s, and this may suggest that was there a selection bias. The clinical deficit was on the lower side. The median NIH was 6, and in the anterior circulation thrombectomies, the rate of recanalization is very good, up to 85%. If you see, these numbers were lesser. So in the distal, it was only about 70%. Could this be because the devices that we have are not optimized for these distal vessels? So for ESCAPE, they exclusively used a stent retriever from Medtronic. So is it because we don't have the right tools to open up these vessels? Treatment appears to be more nuanced. So it did take a longer time to randomize these patients and start treatment. So did that contribute? There were a lot more usage of general anesthesia compared to the earlier trials. So did all these factors, did that account for the lack of benefit in these trials? We'll have to see. I'm sure you're going to see more about this, but this is the ground zero, and I'm sure there's more data which is going to come up in the ESO conference this year, just last week. Maybe MRS is not the best, outcome. When they looked at stroke volumes in the distal trial, It didn't seem to be better in the patients that underwent thrombectomy. And in the ESCAPE-MEVO trial, those patients who were intervened on very, very early actually did show a signal of benefit. So I'm sure there's more to come on this. But right from the beginning, right from the early window large vessel occlusion trials, we know that we need to open up the artery very, very quickly, and we need to open it up effectively, right? So we need to get a good TK2B3 reperfusion. They had better outcomes, and the faster you open it, they had better outcomes. So how do we raise the standard? The problem is that we are doing quite well. We open up the vessel in almost 85% of the cases, like I said, but still, overall, it's only about half of our patients who achieve good functional outcome and MRS of 0 to 2. So what can we do? Of course, there are many things, right? Systems of care, getting the patient in earlier, public education, all these things. But what can we do in the angio suite, right? So we raise the bar. We achieve TK2C3, right? This is almost perfect reperfusion, where most of the territory is revascularized and there's reperfusion except for small hangouts. And then we want to open up the artery with the first pass that we do, right? So opening up the artery as soon as possible and open it up nicely. Will this improve? So this is where we come to adjuncts. Will the use of a balloon guide help us in opening up the arteries faster in the first pass? I wait keenly to hear the next couple of talks. These are all the newer generation of stent retrievers. So compared to the initial designs, there has been a lot of engineering which has gone into the newer generation of stent retrievers. And now you have stents which are designed with drop zones, and they have microfiltration kind of meshes to prevent distal emboli. So there's a lot of advancements in technology and engineering, which again help us to open these vessels better. What about techniques? There are some which are very resistant to opening, especially those at bifurcation. Can we use variations of technique, like using 2 stent retrievers to open up? Again, there are some practitioners who do this. Contact aspiration, can we get bigger catheters, right? So this is a 0.8 catheter. So if you look at the standard size of a middle cerebral artery, which is 2.7, so these 0.8 catheters are almost occlusive over there and probably will provide better suction, better aspiration, and flow arrest. So is this the answer to opening up these blood vessels faster and better? The CHOICE trial was another interesting trial which came out 3 years back, where they gave intra-arterial thrombolysis, and it showed a very, very significant improved benefit. And the concept is, we open up these vessels, but is the distal microcirculation still occluded? So can giving intra-arterial thrombolysis improve benefits? So a bunch of studies have come after that. The post-UK and post-TNK were negative, but after that, again, from China, we have some positive trials, and I think you're going to hear a lot more about this. So basically, what else can we do to improve the outcomes of our patients so that they achieve better outcomes? So I'll conclude over here. So certainly I tried to kind of give you a whirlwind trip of what mechanical thrombectomy has been over the last 25 years. But clearly, there's been significant advances. So mechanical thrombectomy is a very, very effective treatment. And I've shown you that, there's extremely robust therapeutic benefit, and the indications are, ever expanding. I didn't speak much about multimodal imaging, but what we should aim or aspire to do is, try to include patients without being overly restrictive. And the new data definitely warrants modifications of current treatment algorithms. Thank you very much for your kind attention.
Excellent, Seby. So I'll turn it over to you if you'd like to introduce Professor Wim. And I think what we decided is that we'll open up the board for questions after all the talks have completed. Okay.
Got it. So it is my pleasure to introduce Professor Dr. Wim van Zwam. He really needs no introduction for the stroke community. So he is a neurointerventionalist, neurointerventional radiologist working at Maastricht University Medical Center in the Netherlands. And as I said in my presentation, this is the 10-year anniversary of Mr. Clean. And Professor Wim was the principal investigator of MR Clean and MR Clean Late. So large trials which have completely revolutionized stroke treatment and help the community. So he's going to be talking about state-of-the-art balloon guide catheter in the use of acute ischemic stroke. And without further ado, I will pass it on to Professor Dr.
Thank you very much, Dr. Seby John, and what a fantastic, extensive overview you gave of the past 10 years. That's very nice. Let me see if I can share the screen. So you see my screen now?
Yes, you can make it full screen.
Okay, so the task for me now is to talk about the use of balloon guide catheter in treating acute ischemic stroke. You heard all the advancements that we had made over the past 10 years from Dr. Seby John. We expanded the indications from the 6-hour time window and an aspects of more than 5 to low aspects, late window, basilar arteries. That's a new territory as well since we started. Maybe the MEVOs are somewhere the limit where we can go to, those distal occlusions. But what did not change was the debate on the use of a balloon guide catheter over the years. I know from the beginning already there were physicians that really loved to use a balloon guide, and there were others that said, no, that's too cumbersome, it takes too much time. So let's go over it, and let's first have a look, what is a balloon guide? Well, probably most of you know what a balloon guide is. It is a guide catheter through which you advance your other catheters. And at the end of this guide catheter, there's a balloon that you can inflate to block the flow. Here you see how it works. So at the left side, you see this balloon guide in the proximal artery. And then in the distal end, intracranially, you try to remove the clot either with aspiration or with a stent retriever or combined. And in the meantime, you inflate the balloon to stop the flow. And ideally, you also aspirate on this balloon guide catheter, so you get even reverse flow, preventing to lose emboli that go more distally. So that's the main task of this balloon guide. And here you see an example. So here is a clot stuck here at the left side, left upper side, and at the right upper side, you see this balloon guide. And as soon as the balloon is inflated, you see this nice light particles that will stop flowing. So here you see the balloon is inflated, this stops flowing, and then when they pull on the stent retriever, they reverse the flow by aspirating on the balloon guide. And then they pull out the clot. This is a quite tight clot, but if you lose some fragments, you aspirate those fragments into your balloon guide. And then you deflate the balloon, you have antegrade flow, open the vessel, and hopefully you don't have any distal emboli. That's the way these balloon guides work. So it seems that there's only hooray and it's only positive, but there are, of course, some disadvantages. This is a nice overview from 2021 from the group in Calgary, Mayank Goyal. And there are some, as I said, disadvantages. It's more rigid, sometimes more difficult to navigate than a standard guiding catheter. You need a larger sheet. Most of the balloon guides are 8 or 9 French, the outer diameter, so you need an 8 or 9 French sheet in the groin, which you do not need with a normal standard guiding catheter. Therefore, if you advance them, you already, during the advancement, you have some risk of vasospasm, and especially if you inflate the balloon, and if you overinflate, then the risk of dissection even increases. So that is a risk. It takes some time. My experience is that if you do the groin puncture and your nurse is preparing the balloon guide, you don't lose that much time. But anyway, they are a bit more expensive than standard guide catheters. Now, already in the early years, there were comparisons between the use of a balloon guide and a normal guide catheter. And this is one of the first publications that I know is from 2 German hospitals. In one hospital, they used a balloon guide, and the other one, they used a normal guide catheter, as you see at the bottom. And they found a significant difference between the two centers. Of course, there's some center bias. But it had it gave the impression at least that using a balloon guide led to shorter procedure times. So the preparation then didn't take much extra time, and you are faster in opening the vessel, and that ultimately led to better technical outcomes. So the TICI grade, you probably know the TICI grade. TICI 3 means that the vessel is completely open, and 0 is it's still completely occluded. and 2B is more than 50%. And that's a successful opening of the vessel. And that was definitely better with the balloon guide. Since then, there were several publications. Here are some of them. Most are registries where they looked at the use of balloon guide. And because not everybody used the balloon guide, it was easy to compare the outcomes between balloon guide and no balloon guide. And for example, if you look at this one here from the Stratis registry, you see that using a balloon guide led to better outcome. Here they compared using a balloon guide with a normal guiding catheter only, or a distal access catheter where you also can do your aspiration. And they showed that using the balloon guide compared to a standard guiding catheter led definitely to better technical outcome after the first pass. So TK2C is even more than 90%, and TK2B is more than 50%. So better outcomes in a technical success if you use balloon guide. And here, if you look at clinical outcomes in the Trevo thrombectomy, another registry, technical outcome definitely better, but also the clinical outcomes by using these balloon guide were better than without balloon guide. These were the that was over the past 10 years, the publications that I saw that compared these use of balloon guide with no balloon guide, and they appear to have all a better outcome after using a balloon guide. Most of them were in combination with stent retriever. And the question is then, is it also better if you do it in combination with distal aspiration? Because then you have already a way of removing the clot by aspirating on your distal access catheter or your aspiration catheter. If you do that, you have this setup. You have an aspirator on your balloon guide here. And here you have the distal access catheter where you also aspirate. This is both with syringes. You can do that with a pump as well. But the combination, is it even better with a balloon guide in this situation than using a standard guiding catheter? Well, there's one nice publication from a Korean group, and it's a large group, as you can see here. So these are patients where only aspiration was used, distal aspiration, and then combined with a balloon guide catheter led to a higher success rate. Technically, first pass recanalization, I'll come to that later, and that has been mentioned by Dr. Seby John also. This first pass recanalization is an important outcome measure for technical success. We know that first pass recanalization definitely leads to better outcomes. So the outcome at 3 months was also much better if you use a balloon guide in combination with distal access catheter. Now, in our own Dutch Mr. Clean registry, we also looked at the use of balloon guide on the upper row and non-balloon guides in the low row. That effect was clearly visible when you use a stent retriever in your first attempt, but it's less visible. And in fact, there is not much different, at least not significant, if you use it in combination with an aspiration first attempt. That was what we saw in our Mr. Clean registry. And there are large numbers, especially in the stent retriever group. Now, you can combine stent retriever with distal aspiration, as you know, and these techniques have different names like SAFE or Solumbra. It's the combination of distal access aspiration together with a stent retriever. And if you combine that with a balloon guide, this is the balloon guide, so this is the syringe where you inflate the balloon. You can dual aspiration and a stent retriever, and this is again from the group in Calgary who published this. It's a nice publication with a lot of details about technical improvements. And they named this the badass approach, balloon guides with large bore distal catheter with dual aspiration with stent retriever. And that, in their opinion, is the best way to do a thrombectomy with the highest chance of a good technical success, but also better outcome. Here you see an overview where they compared the use of balloon guide or no balloon guide with this combined technique. And in fact, this is the French group, they said it was not superior in this situation. So using it in the combined technique, combined stent retriever with distal aspiration, their balloon guide catheter was not superior in their study in 2021. A few other things that I wanted to show from the literature. Here they looked at the more distal occlusions. You just heard from Dr. Seby John, that the verdict is not out for distal occlusions. In fact, the trials that have been published and the one that has been presented did not show a benefit of endovascular treatment in those medium vessel occlusions. So here they looked at the use of a balloon guide. Well, they had lower Tiki scores and decreased first pass effect, sorry. And longer procedure time, so all negative for using a balloon guide. But the reason they use a balloon, we use a balloon guide, primarily is to reduce the risk of distal embolization, and that occurred. So that was true. But in fact, this is not the most positive outcome, I would say, by using a balloon guide compared with non-balloon guide for distal vessel occlusions. Now, here is a very extensive overview of all the literature, well, at that time, 2021, and that was in fact the studies that I used in previous publications, because if you combine all those studies here, mostly registries again, then you see that there's definitely a benefit of using a balloon guide catheter. Here about distal emboli, here about the MRS 0 to 2, the standard outcome at that time, favors balloon guide catheter. There's another one, Tiki 3, so the successful, and then the really complete recanalization was definitely better by using a balloon guide. And last one, the first pass effect. So first pass effect, complete recanalization in the few studies that looked at it, definitely better if you use a balloon guide. And this first pass effect, well, nowadays, if you look at techniques, devices, etc., it's a bit the holy grail. You have to have a high percentage of first pass effect, and that will define the success of your device. Here you see an overview that if you have a first pass effect, that the outcome is definitely better compared with a multipass. Of course, in all those studies, there's a bias. There's a reason that you need more passes, more difficult vessels, maybe more intracranial atherosclerosis. But if you achieve first pass effect, then definitely the outcomes are better. And what are predictors of first pass effect? Well, you can guess. In this very large French registry, they defined some of the predictors of a first pass effect, and although this number is not significant, the balloon guide catheter and also general anesthesia, but this is not the topic of today, but a balloon guide catheter led to a better first pass effect, while general anesthesia had the opposite effect. So you had less first pass effect by general anesthesia. But for balloon guide catheter, it was higher, the first pass effect. And that is so one of the predictors of first pass effect. And I think still that balloon guide catheter is beneficial. And I show you more reasons why I think it is beneficial later. One of the latest publications we had from our own study here in the Netherlands, where we did a survey about the use of balloon guide catheters. And there you see that the use of balloon guide catheters varies enormously among physicians. And what we found most interesting is that many physicians use a balloon guide catheter as a standard, but in the majority of cases, they even do not inflate the balloon. Why? Well, if your guide catheter with or without balloon is already in an occlusive situation, you have already blocked your flow, so that you do not need to inflate the balloon. So if you read papers where a balloon guide catheter is used, it does not always mean that the balloon is inflated during the procedure. These are some more outcomes of a survey that we did. And you see that 50% preferred a non-balloon guide catheter as a first choice, and some even never use a balloon guide catheter. So there's some variations in whether you choose to use a balloon guide. Some say, okay, if I have a tandem occlusion, I don't want to use a balloon guide. I want to have a smaller guide catheter, and I know that I'm already in an occlusive vessel if I go to a tight stenosis. Well, there are some reasons to use or not use. And I think that hardly anyone uses such a large guide catheter in the vertebral arteries, so not in the basal artery occlusions. Now, the latest results of trials, and that is when I come to some other examples, but the latest results of trials, this is a Chinese trial, the PROTECT MT, and this was a bit surprising, I would say, because here what you can see, the use of a balloon guide definitely led to worse outcome than a conventional guide. And this was a randomized controlled or clinical trial. Another trial from the UK, it's the Prof trial, multicenter blinded endpoint randomized clinical trial again. And here they found a little bit better with what they call flow arrest. So either you have flow arrest by just an occlusive position of your catheter, but at least when they used a balloon guide catheter, you had flow arrest. They had better outcomes if they use flow arrest or a balloon guide catheter. So how come that you have these differences? In one randomized study, you have worse outcomes, and here you have slightly better outcomes when using a balloon guide. These are the differences between those two studies. So the ENTs were definitely less if you used a balloon guide in the British study, but not in the Chinese study. There it was the same. Intracranial hemorrhage was definitely a bit higher if you used the balloon guide in the Chinese study, while it was lower in the British study. Mortality was higher using a balloon guide, while it was lower in the British study. Here, there is no effect in first pass TK2C in the Chinese study. Well, it was definitely higher in the British study. And the final TK3 at the end of the procedure was higher in the British study, while it was not different in the Chinese study. How come? Are there explanations for these differences? Well, there are a few things that might explain these differences. First, in China, the experience with balloon guide catheter was very limited because in most of the places they were not available. So they were used for the first time during this study. Furthermore, in the protocol, it was recommended that you place the balloon guide catheter in the proximal internal carotid artery, while the conventional guide catheter had to be placed distally, more distal in the internal carotid artery. That is a significant difference because now with the newer generation balloon guide catheters, we advise and the industry advises to place them as distal as possible. And of course, if you place your guide catheter more distal, you have more effect of your aspiration, you lose less fragments. So if you would place them probably both in a more distal position, you will have other outcomes of a study like this. That is all about why do we use the balloon guide. But there are other advantages. At least in my hands, I see many more advantages of using a balloon guide. So it is also protecting distal emboli when you do carotid artery stenting. Nowadays, we do that mostly in the acute setting, but sometimes in the elective or semi-elective setting as a secondary prevention, we do carotid stenting. And then we also use a balloon guide. At least I always use a balloon guide then, and I use it, as I just explained, to inflate it, have retrograde flow by aspirating on the balloon guide, and I prevent distal emboli. Finding the right lumen, I will show that in an animation after this. Reducing pressure after a perforation. Of course, as soon as you have a perforation, you can inflate your balloon and you reduce the pressure in the brain vessels. Floating up, I will show you as well, in difficult access, and stability if you have difficult accessible vessels more distally. So emboli protection in carotid artery stenting, well, it is quite clear. This works the same as emboli protection in distal occlusions. You inflate the balloon and aspirate like here. And your aspiration is usually enough to overcome the inflow from the external carotid artery. There are systems where you can place a balloon in the external carotid artery and you do more or less the same, but just placing a balloon guide here will prevent distal emboli in normal carotid artery stenting. And here you see another example. Here is a stent placed, here's the balloon guide catheter, and here's a post-dilatation. And again, you prevent distal emboli if you do block the flow and do retrograde flow by aspirating. This is an interesting indication, and I've used it myself, and I used some images from Jan Galla from Switzerland. If you have a dissection like this, you but you quite often end up in the wrong side of the intimal flap, so in the wrong lumen, and it's sometimes very difficult to find the true lumen. And what helps if you inflate the balloon and you start aspirating, this flap will go to the right side. You can check that by if you want to give contrast on the other side, and then you will see that contrast is going here. This is an example of it. I hope you can see it. So you inject contrast in the one side, then you will see that the contrast is going to the true lumen. The true lumen is quite tiny, but in this way you can find the true lumen. I tried it once, and to my surprise, when you aspirate, immediately you enter the true lumen. So that's an advantage of using the balloon guide as well. And as I said, reducing your pressure after a perforation. This is a case, MCA, M1 occlusion. We opened the vessel, but we had a huge hemorrhage after that, probably by perforating a small perforator with a wire, or the microcatheter is both possible. But the first thing that we then do in these cases, we block the flow, we reduce the pressure here, and that helps stop the bleeding. The bleeding usually stops by itself after some minutes, but by reducing the flow, it goes faster. And you still have time. For example, what we do most of the time, we place a temporary coil, leave it for a few minutes here to completely block the flow, and then see what happens. But this helps enormously. It gives you some more time. So here's a temporary coil that we usually nowadays place when we have a bleeding. This is another situation. If you have difficulty pushing up your guide catheter, it sometimes helps if you inflate the balloon, not completely, just half, and then you have the flow that helps you pushing up your guide catheter. And last thing, if you inflate your balloon here, if you have difficulty getting your distal access catheter or even your microcatheter along very difficult curves, of course, this is not a difficult anatomy, but if you have difficult anatomy, it sometimes gives you stability, inflate here. Here it is fixed, then you have more power, pressure to advance the more distal catheters that you want to use. So, balloon guide catheter, yes, less distal emboli, that's the reason that we use it mostly. It will therefore increase the first pass effect, less distal emboli, less TK2B, 2A. You see that effect more clear when you use stent retrieval thrombectomy as your first choice. And in ADAPT, so distal aspiration as first attempt, or the combined technique, it is less clear. But even if it is less clear, it's not harmful. And it has different advantages, I would say, to use a balloon guide, and especially with the later balloon guide catheters that are more flexible and you can place higher in the internal carotid artery, probably have even more advantages of this balloon guide. I think that's more or less what I think about balloon guides. So I still use it as a standard technique. And I know that there's a huge debate that some people prefer still without using a balloon guide. Well, there was a registry with the Bobby from Neurovascular, and Dr. Tobias Buck will tell us more about what came out of this registry. Okay, and then we do the Q&A after that, so you can still put your questions in the Q&A box. In the meantime, I will give over the word to Professor Tobias Buck-Berends. He will present, as I said, the STRAIGHT trial, which he was the PI of. And I don't know if you know Professor Tobias Buck. He is a German neurointerventionalist, started his education from 1996 to 2002 in Erlangen and Bonn. And he graduated finally at the University of Munich in 2003. He did 1 year of surgery, 3 more years in radiology before he started radiological education in Großhadern at the Ludwig Maximilian University in Munich in 2008. And from 2010, he worked as senior neuroradiologist at the Klinikum Rechter Isar in Munich before he became head of the neurointervention and assistant director in 2017. He is internationally acknowledged expert in neurointervention, and he published numerous scientific contributions in highly ranked international journals on stroke and neurointervention. So I'm very happy that he will tell more about what he found in this registry. And I pass the word now to Professor Tobias Buck-Berends.
Yeah, Dirvin, thank you very much for this really nice introduction, and also for this really complete overview that you just gave us about the topic of the balloon guiding catheters. And I'm also really happy to be able to present to you the straight trial final results, which are actually not yet published. So these are really new data that I will present, and these are my relevant disclosures regarding this talk. Just to begin with, everything that you heard until now, or nearly everything, is based on data that we got from evaluations of older generation devices. So as Dr. Seby John already told us, there has been really a very, very fast progress in the development of new devices in all aspects of treating strokes. And this is also true for the balloon guiding catheters. And as Wim already said, the older generation devices, they really had some issues we had to struggle with, especially they were quite stiff. And of course, they had not a lumen where you could really work with the larger distal aspiration catheters like the Sophia Plus, for example. And the only evidence that we have from newer generation devices, which came out the last years, and I would say this is, for example, the Walrus, this is the Emboguard, and this is the Bobby. They all these three catheters, they have overcome most of these problems that we had in the former times. And this is the only evidence that is already published. This is a retrospective evaluation of the Walrus.
Tobias, can you share your screen?
Oh, I did
your
not.
slide yet.
I thought I did. Oh, you cannot. Okay.
Yes, now we see it. Thank you.
Okay, I'm sorry. So, okay, then you didn't miss much. This was the only one before. Okay, so yeah, this is the study that has been published so far regarding the evaluation of the Walrus, one of the newer generation devices. But this was a retrospective evaluation in several different centers, and what I can now present is a prospective evaluation of the Bobby device, which has actually these new characteristics also that are similar to the other newer devices. Mainly, they are much better trackable, they are much more stable, and they have a bigger lumen. These are I think, the main issues that have been fixed. So the straight study itself was a prospective trial, multi-center, single-arm, GCP standard. So it was really a core lab controlled, high-quality data that we gathered here. We enrolled patients from these trials, so 9 centers in Germany and Switzerland. 171 patients have been enrolled. And our primary endpoint was actually a technical one. It was successful reperfusion, TQ2B or 3, call-up control, of course. But we also had a very close look to a lot of secondary endpoints, including performance endpoints, safety endpoints, and of course, outcome data. And I will now give you an overview of all the results that we have. The inclusion and exclusion criteria were quite standard because as we had no control group, we tried to be quite comparable to the existing literature. So we concentrated on anterior circulation, large vessel strokes, and aspects larger than 6, and clear stent treatment, which was clear at the beginning, was excluded. So we performed an interim analysis after 115 patients, and then we saw that the primary endpoint was already met, and then the further enrollment was stopped early. And now I present the data from these 171 patients. We have a full analysis set, which includes all of these patients, and we have a per protocol patient set, which is a little bit smaller in the number, but these two sets do not really differ in all the major aspects. So the medical history, the baseline data were very similar. That you can see here a comparison. So the stroke severity was high in both groups. Aspect was identical, and all other key aspects that usually define outcome and also technical success were comparable. So I will stick to the larger patient population in the further slides. These were the occlusion sites that were treated. Interestingly, you see a slight shift from at admission and prior the actual intervention, which reflects the further the shift of the occlusion sites to the more distal parts of the vasculature. So we have less M1 occlusions prior to the MT and a little bit more M2 occlusions, which is, I think, a little is interesting. Procedural characteristics were also standard, quite fast time from stroke onset to procedure start. Also, the procedure itself, I think, quite quick with 40 minutes. Most of the patients have been treated in general anesthesia. The strategies that were used were, in most of the cases, a combined one with stent retriever and distal aspiration combined. And most of the interventionalists, they stayed with their first chosen strategy in 70% of the cases. Additional therapy was not very common, only 4 intracranial stentings. And interestingly, 2 patients could be recanalized without any additional treatment, just by aspirating from the balloon guide catheter. That was, I think, also a very interesting small result. So the first thing that you do when you start your procedure is, and the most important one, is that you are able to place your guiding catheter as distal as possible, what Wim already said. And this was possible in nearly 2/3 of the cases, that it was possible to place the catheter at least in the mid-segmental part of the ICA. But of course, this is absolutely dependent or interconnected to the anatomy of the ICA, obviously. So now I'm coming already to the primary endpoint, which was the TK2B or TK2B3. And this was nearly exactly the same as in the interim analysis with 95%, and also nearly identical to the previously published number in the retrospective walrus study. And also the first pass rate with 63% was really quite high, and also very, very similar to the previously published numbers. But these data are, as I said, collab controlled and prospective, so with a much higher data quality. Now, when we come to the more when we have a more deeper analysis of our results, what we saw is that it was really, and also was what Wim already said, it was really important that it was possible to place the tip of the balloon guiding catheter as distal as possible, because we see a drop in the first pass rate when you see here between the mid-segmental part and the proximal part of the ICA of nearly 20% or 15%. And of course, this was also interconnected to the vessel tortuosity, which we also evaluated during this study. If we look at the safety outcomes, we had no symptomatic intracranial hemorrhage within 24 hours. And the embolization rate in new territories was 6%, which is actually the event that we want to prevent by using the balloon guiding catheter. And interestingly, nearly all of these emboli that we saw have been, they occurred only if we saw a hyperdense media sign in the initial imaging, which probably reflects a high erythrocyte content and a less stability of the clot that causes the occlusion. Now, in the end, we come to the functional outcome, which was very high rate with 61%. But of course, as this also reflects our inclusion and exclusion criteria, which is clear, but the MRS rate is nevertheless really high. And also the mortality rate is low with 8.5%. So these are the key results from the trial itself. And in the end, I would like to give you an example of a case where you can see how you can really use these kind of balloon guiding catheters, which is different to the older generations. And the concept itself was already shown by Wim. So if you are confronted with these kind of anatomy where you have really a hard time to get every catheter is difficult to get here in the right position. And here you see a video how you can use these newer devices. This is a Zim catheter, which is now navigating in the proximal ICC, in the proximal CCA. And afterwards, you cannot really advance this catheter further. But it is possible to advance the balloon guiding catheter upwards to this proximal position in the CCA. And then what Wim already showed, if you inflate or partially inflate the balloon, what you really get is an additional force from the bloodstream that is stabilizing your catheter. And now you can advance your diagnostic catheter further upwards and then deflate the balloon again. And then you have enough stability to really go up with your catheter to the ICA or to the bifurcation. And then you have this situation where you see the carotid T occlusion, and you see here another challenging anatomy to when the goal is to bring up your guiding catheter up to the petrous bone. And what you can do then is you just use your traditional anchor maneuver. You place the stent retriever in the M1, and then by just pulling a little bit your system, then it is possible to go upwards with these catheters to the position that you really need to have to be successful. And then if you really reach this position, then you can inflate your balloon, and then you have optimal prerequisites to get a good result in your maneuver. And this is then the final result of this example. And I think the most important thing is that you keep in mind that at this position, the ICA is fixed in the bony canal of the skull base, so it cannot really collapse when you put some aspiration force on it. And that prevents, or that gives you the opportunity to really aspirate all the debris and all the fragments that you created during your maneuvers. So in conclusion, I think that also the independent evaluation of one of this new generation devices shows a very good safety and efficacy profile. There have been no device malfunctions, and the device placement was also, when you compare it to other devices, fast and also successful. Obviously, it always depends on the vessel tortuosity. That was the primary endpoint, very, very high. So now I think we have some new evidence for the newer devices, but of course, we probably will need some new randomized controlled trials after the controversial results from the previously shown two trials. And we saw also that the vessel tortuosity and the optimal balloon guiding placement and also the clot characteristics play very important roles in the final results that we can achieve with these technique. So thank you very much for your attention, and I'm very happy if we can now dive deep in the discussion.
Excellent overview. Thank you, Tobias, for that thorough review of the Bobby device and the straight trial, as well as that very nicely illustrated navigation and placement, optimal placement. And then prior to that, obviously, we had Wim, who went over the literature for balloon guide catheters, and Seby, obviously, overall review of mechanical thrombectomy. So we're opening the floor now for any questions. You can post them in the Q&A section, but otherwise we're going to start off with the discussion. So Seby, you want to go ahead?
Yes, again, thank you to both of you for those excellent talks. Either of you can answer, but Professor Wim, Professor Tobias, how do you choose which cases you go with the balloon guide catheter? Do you use it for all your cases of anterior circulation stroke, or is there anything that you look at in the preoperative imaging that will definitely sway you one way or the other? How do you choose?
Well, in my situation, we always use balloon guide. I always use balloon guide in the anterior circulation. There are, as far as I know, no contraindications. Even if you go from the arm, I prefer to go brachial than radial. I know that many people, especially in the US, they go from radial, and then you cannot use a balloon guide. Then you need too big sheet. That's not allowed by the radial artery. But if you go brachial, you can still use a 7 or even an 8 French sheet, and then you can still use a balloon guide. But well, 90% or 95% of cases we come from the groin, and then my standard setup, and that also makes life easier also for the technicians when you have a standard setup. And the standard setup is a long 9 French sheet, a long 9 French balloon guides, and then I use either Sophia or Red 68 or whatever distal access catheter you would like to have. We have several, but the standard is Sophia 6 in our case. And I use a microcatheter microwire to go up. So that is more or less the standard setup. And it means we always have a balloon guide in place. But also in my situation, many times, I don't know if it's 50%, but in many cases, we don't inflate the balloon, because when I am in a very tortuous vessel or in a stenotic carotid artery, then I have already flow arrest. I don't need to inflate the balloon then.
Tobias?
Yes, it's more or less the same in our center. So it is absolute standard, and I see it very similar. I think there is no really disadvantage of using these new balloon guiders, maybe except price. This is, of course, they're a little bit more expensive, but if you only look at the performance, they are at least as good as our conventional guiding catheters, and you always have these additional possibilities, and even in cases of complications, and so they are really helpful in many other situations than only the usage for the emboli protection, which is, I think, of course, key, but I don't see a disadvantage. So, and as I think as Wim also, we use it more and more also in elective cases like stenting and preventing emboli, or having more control in, if you do, for example, vessel occlusions, so parent vessel occlusions, or these kind of situations.
Yeah,
Professor Wim, you mentioned Protect MT, and I've read that paper. I haven't read the UK paper, but is part of the reason the results which showed in the Protect MT that they used, older generation of the balloon guides? I think that's valid with, today's presentation of Bobby, and how these newer generation of balloon guides are, so much more navigable, and it allows for, larger aspiration catheters. Do you think that was a factor? And I don't know what the UK paper used in terms of balloon guides.
I'm sorry. I assume that the usage of the older generation devices led to the recommendation that they only had to place them in the proximal part of the ICA, and I think this is one of the crucial drawbacks, because and that in combination to not really being very used to these devices, then you maybe have the problem that you just create this kind of collapse sometimes, and you do not let it just passively flow out before you reopen the balloon. And I think this is really one of the major problems. And I think the UK trial, they use Flowgate 2, which is a okay balloon. It is much better than the first generations, but it's quite floppy, and you have more problems with the Flowgate than with the other guiding catheters. But the advantage of this study was they used the Flowgate in both arms. So they just divided into inflating or not inflating. But it was underpowered, so a little bit for really good data.
Yeah, they looked at flow arrest or no flow arrests, and that was interesting. So I was also wondering what would make physicians now use the balloon guide catheter. I mean, we see the advantages. You say there's no harm in it. I mean, it's not worse, but I think non-inferiority will not lead to the use of it, because they're definitely more expensive. So you need you need better results than non-inferiority. So we have to prove somehow that the outcomes are definitely better. And that's not yet convincing. Definitely not with the Protect MT, but as I said, that's older generation, different use, the intervention arm, the physicians were not so used to using a balloon guide, so that has some disadvantages. But then, yeah, we don't have, from registries, from all the data, we have some indication that there is a benefit, but that is seemingly not convincing enough. So what do we need? Toby, as you said, a randomized trial now with the new balloon guide catheter, yeah.
Yeah, I think we have to do these kind of trials now with better devices, and also with the experience that we really have to be careful in the planning of these studies and to avoid any faults in the setup. But I think this will be necessary.
That's great. I'll come back to that discussion. I have just a couple of quick technical questions for those of us that have not used the newer generation devices. So we're talking about with regards to the Bobby device, it seems to be more navigable, but is that at the expense of support? Have you ever had any problems where you're trying to push your distal access catheter or, you know, stent retriever up and you found it less supportive, less rigid, or is it just that the position is so high now that it's wedged in there that you have good enough support? Are there any concerns?
Rios, what do you think?
Well, in my experience, I do not really have a problem with stability. The catheter is built with a tip, I think it's 10 centimeters, which is quite flexible. And then you have a quite stable part, and usually it's not a problem to really get this stable part over the aortic arch. I had very, very rare cases where actually it was really difficult to get up this stable part around the curve. But if you use the additional stabilization method, then it's usually not a problem. And if you have the stable part in the CCA, then it's I think a very stable setup.
So that's the distal 10 centimeters, that if once you have that engaged, you can partially inflate it, is what you said? Or and it drifts up. You talked about how it drifts up.
Yeah, you can use it to bring something through the catheter to give you then more stability to get in a third step then the more stable part upwards.
Okay.
Yeah, there are in fact two ways that I try to show this floating or sailing up. It's not really that it goes by itself, but it has some extra force, so you still have to push it upwards.
Sure.
But if you got stuck and you can't push it upwards and you inflate the balloon a little bit, you have the extra force of the blood flow. That helps you sometimes. That is the idea. And then the second step, that is what Tobias showed, that if you want then to have your distal material getting along some difficult curves, you can inflate the balloon for stability. So then you make your position stable and you can push up the other materials, because instead of pushing the whole system back into the aortic arch. Another thing, what I said, that our standard setup is with a long 9 French sheet. And the reason for that is that even with the older generation balloon guides, like we used the Merci and the Cello, they were very stiff. But even then, in difficult aortic arches, type 2 or 3, when you could not advance your material, you still push the whole system back into the aortic arch. And if you use a long sheet, and that's my experience over the past few years, if you use a long sheet that you can place into the common carotid, or even if you place it at the right side in the brachiocephalic artery, you overcome this problem of pushing back the whole system into the aortic arch. It never happens anymore if you get your long sheet there. And then whatever guide catheter, well, floppy, I wouldn't say, but less stable guide catheter, the stability you have already reached in the aortic arch. And then you have the the advantage of a very floppy distal end to go much higher than with the previous balloon guide catheters. So that for me is now the ideal setup.
Great. And quick question before I turn to some of the questions posted online. What do you guys use for hemostasis when you're going up to a 9 French sheath? What's your standard?
Yeah, we use angio-seal. Probably
Oh,
you
sorry,
know.
can't hear you.
You can't hear me?
Yeah, now I can hear you. Yeah.
All right. So we use angio-seal, and probably
8
you
French?
know it, the most simple
8 French. Yeah. Okay.
closure device, and we use it up to 9 French, and
Up
it
to
works
9.
fine.
Yeah. Got it.
We use also angio-seal, and we
Angio-seal.
usually use only 8 French axis, and we switched from the long sheath, the 9 French long sheath, to the 8 French again back after the switch to the Bobby.
To the Bobby.
The flow gate, we always use the long sheath.
No, got it. Excellent. All right, so we have a bunch of questions online. One is with regards to training your team. Could you talk about the learning curve? I think you both alluded to the fact that your nurses or your techs are preparing this for you. So you find that this is something that they do quite reliably and they can do it quickly?
Yeah, and that requires some training indeed. By the way, at the moment I am in Amsterdam. I was training at the skill center, physicians from all over the world that came to Amsterdam to the skill center for 2 days training. We have sometimes in our hospital systems, mostly brought by the industry, simulators, flow models. We are trained, our fellows are trained, but also our technicians are trained. So once in a while they come to our hospital and then we do a whole day training. And the other thing is, of course, at the table, we always want to have the technicians involved. So they have to do the steps. So they need to get the experience. And it's true, if you have new technicians, it takes some time before they really get familiar with all the steps. It's not a very simple procedure. You need several steps in preparation. So that has a learning curve indeed. Yeah.
Yeah. And then kind of related to that, how do you see the prep time added to the length of the total procedure? And I think there were some slides that showed that overall, actually, the revascularization time goes down.
Yeah.
So there may be some leading prep time, but the revasc time ultimately is lesser. Is that correct?
Yeah, in my situation, I said usually one does the puncture and the other one preps the balloon guide, which takes you 2 minutes. I mean, you don't lose time with it. Tobias, I don't know if you have different experience, but
No, I think if you're used to it and you have already the learning curve is behind you, then I think then you really do not really lose a significant amount of time. And of course, they are a little bit different. So the Bobby has a different kind of preparation than the other two. So if you're not used to how to prepare the for example, these double lumen microcatheter balloons, so Eclipse or Scepters, this is the way how you have to prepare the Bobby.
sure.
Then you just need a little bit time to get used to that kind of preparation, and it is also that you have to do it beforehand. The other two, it's in principle it's possible to just prepare them in the body, but you have to also be sure that you give them enough time to get wet, that the balloon itself is not damaged, because it has to be really wet before. And these are some small things that you should not miss, and so therefore you need some experience with it.
A bit of a learning curve, but definitely doable. It seems like you've both been able to implement it in your practice as the standardized first approach. So that's good. The next question goes back to actually earlier discussion with regards to cost. And I guess my statement would be just kind of elaborating on what you said earlier, Wim, was that, we don't have evidence yet, right, that it's superior. Maybe it's non-inferior, and we don't have randomized trials. But in in the part of the world like ours, we're a low middle income country, where you actually, a lot of times, resources are limited. At this point in time, the data isn't strong enough or robust enough where you would say that this is your first strategy. I mean, you'd probably pick a stent retriever or thrombolytics over taking a balloon guide catheter. And I think until we have some of that stronger data, it's going to be harder to implement this in some of the lower income countries. I wonder about your thoughts with regards to that. I'm presuming it's covered right now under the insurance programs in Europe and through your national health systems, but if you could comment on that.
Yeah, I agree that there is evidence. I showed you this systematic review, meta-analysis of different non-randomized, mostly registries. There is some evidence, but it's not strong enough to recommend it in guidelines. So also in guidelines, we leave it more or less in the middle. It is, well, there might be an advantage of using a balloon guide catheter. And for me, the additional advantages and what we also used or mentioned today in the workshop is that as soon as you have a perforation or a bleeding, a rupture, whatever, then it really helps you. But that's only 1 or 2% of cases. So that's, yeah. But
it's an insurance policy. It's a great insurance policy. It sounds
maybe, yeah.
having that available.
Yeah. But
Tobias, your thoughts?
For cost, I think that is, yeah, they are more expensive. On the other hand, if you look, for example, the comparison between stent retriever and aspiration catheters, that difference in cost is much higher. And in some cases, I would say aspiration is non-inferior. And for basilar artery occlusions in the guidelines, we even recommend to start with aspiration first. So then you save a lot of money. And well, then the few extra dollars or euros that you spend on a balloon guide doesn't make the difference, I think.
Yeah.
So yes, it is true. It's more costly, but the difference is not that big. And yeah, if you find for yourself the advantages, I would consider doing it, even in low to middle income countries.
So you
Tobias,
gentlemen have, go ahead, Tobias.
No,
Sorry.
thanks.
And you'll have so much experience with balloon guides, you use it for all cases. So what would your, kind of selection strategy be for, as in, especially given the data that we've just discussed, and to interventionalists who don't use it at all, which are the cases that you absolutely would recommend using a balloon guide catheter? Is it, large clots? Is this, ICAT clots, or you suggested imaging hyperdense clots? Is it those with more RBC content? Are there any cases that you would say, I would certainly recommend using a balloon guide?
Well, besides that, I would recommend to just make it your standard, because that helps additionally. I think, well, we do sometimes not use a balloon guider, or we use in the former generation, where we had to use the smaller aspiration catheters in very distal occlusions. I think in these occlusion locations where it's we have a good chance to really retrieve the small clots inside a distal aspiration catheter, then maybe the additional advantage is not as high as you said, large clots, long clots, prone to fragmentation clots like hyperdense. Yeah, I think maybe these are good ones to start with. I don't know how you see this.
Yeah, so what I showed for distal occlusions may be less so the recommendation, but now we know that for distal occlusions, endovascular therapy is maybe not the way to go. Maybe we should do more, well, different techniques like intraarterial thrombolytics. We don't know yet, but the outcomes of the trial are not leading towards use of endovascular treatment in distal occlusion. So yeah, for that case, I would not say, I can't say anything about using a balloon guide as long as we don't know whether endovascular treatment is beneficial at all. But to find indications where I would really recommend it, it's interesting that in the past, I would also think that if you have a tandem lesion, so an internal cervical carotid lesion, I thought, well, I don't need a balloon guide because I have an occlusive position anyway in this stenosis. But nowadays, I would say, especially at those occasions, I would use a balloon guide because then when I place my stent, I have the protection. There was a question from the audience as well. Would you use a filter, for example? Well, we don't do that anymore because for a filter, you still have to pass the lesion first and then place the filter. So the damage is already done. But with a balloon guide catheter, you have protection immediately before you do anything because you can even pass through the stenosed area while you aspirate or while you block your flow. So for me now, for carotid, proximal carotid lesions, a balloon guide is very useful. So in these cases, I would now recommend to use a balloon guide.
Excellent.
Good. Just looking at the Q&A, I think we've answered most of these questions. Any final comments, gentlemen?
No, I
So
think
when is this randomized? Oh, when is this trial coming up, Tobias?
Well, if somebody would give financial support, which enables us to plan this, then we would start immediately. But yes, we are looking for financial support, and I'm not sure how fast this will be.
Yeah, but with the newer balloon guides, I think that the companies are willing to support a randomized trial. I think they're confident enough now to put some money on a randomized trial. Okay, I think, gentlemen, we have to wrap up this perfect webinar now. Thank you all for being with us. I think it was a good session. I think we learned a lot. It was a fantastic overview by Dr. Seby John, and I hope you learned something about using a balloon guide. I don't know if you have convinced you, the audience, but I think there are benefits of using it. Okay, you will have an evaluation form at the end of the week, and once you send that one back, you will get your CME credits. And then I give the last word to Dr. Hussain.
Thank you very much. Thank you all, you gentlemen. It's been a wonderful event and great discussion. Hopefully the audience learned a lot. So before we conclude, I'd like to remind everybody that our annual 10th MENA Stroke Congress will be happening in Cairo, Egypt this year between the 17th and 19th of September. This is our flagship event for the region, and it brings together leading experts within cerebrovascular care. It's a fantastic opportunity to network, to meet colleagues, to learn, and to generate discussions about the management of stroke in our region. So we look forward to welcoming you in Cairo. Mark your calendars for the date. It's on the screen right now, and we'll be sending more details as it gets closer. Once again, thank you all, and goodbye.
Bye-bye.
Thank you very much. Goodbye.